It is just a huge honor for me today to be podcast interviewing Dr. Clayton A. Chan, D.D.S., a general dentist, clinician, teacher, world-class educator, mentor, and is considered by many to be the preeminent educator and authority on neuromuscular and neuromuscular with a G neuromuscular, G&M, dental occlusion. He is a trained gnathologist who has combined expertise in both gnathology and neuromuscular approaches, which is a rare combination of skills in the dental field to treat complex occlusal problems, as well as handling difficult craniomandibular, TMJ, cervical dysfunction cases. His clinical knowledge and understanding on dental occlusion and its relationships to craniomandibular dysfunctions, TMD, orthodontic, orthopedic, and complex restorative prosthetic problems is what helps him convey a unique threefold clinical message to thousands of dentists, specialists, technicians, and dental leaders nationally and internationally. His training and expertise as a general dentist and dental laboratory technician, along with the training in the areas of gnathology, TMD, orthodontics, and mastery of neuromuscular instrumentation, has led him to convey a threefold clinical message. I just said that. Sorry about that. I repeated myself. He's provided more than 4,100 hours. That's 404 days of continuing education since 2009 to the present. He has given over 202 courses on the subjects related to dental occlusion, TMD, restorative orthodontics, advanced electrodiagnostic instrumentation, K7, kinesiograph, myotronics. He has presented to dentists from all over the world, including the United States, Canada, Australia, Japan, Germany, France, United Kingdom, Russia, Singapore, Taiwan, Indonesia, Philippines, Malaysia, Vietnam, Cambodia. I could read his bio for 40 days and 40 nights, but let me tell you this. When I would go to some of those countries, like I remember when I was in Singapore, we did a podcast with Wing Chu Ya and his wife, Louise.
Yeah.
And that was episode...
Louisa.
Yeah, and my God, I mean, they were your idols. They only associated American dentistry with you. And then we went next door to Cambodia and Malaysia, same thing. I mean, I think you might even be bigger in Asia than you are in the United States, which makes sense since they have 5 people for everyone in the North America. But so, gosh, I wanted to get you on the show since day one, and I was podcast interviewing Las Vegas Aesthetic Dental Lab, episode 1224 with Ray Foster, and they said, well, we'll get him on the show for you, Howie, and they delivered. I got the man right today. How are you doing?
I'm doing great, Howard. Thank you for even entertaining the thought to have us on your podcast, and we really are very appreciative to be able to share with you some of our thoughts and thinking.
Well, you're too humble. My gosh. So, we just had a passing of a temporomandibular disorder guru with the late Peter Dawson.
Wow.
This seems to be, well, first of all, what thoughts or words do you have to say to Dawson now that his career has completely passed?
Yes, I tell you, it was a sad day for me because we recognized that Pete was fantastic. He was a real leader, and it really reminded me of the wonderful time I had back in 2007 after I left the Institute. And he invited me out, him and me and my wife, to come out in 2007 to meet him and have a wonderful dinner. And we had a great dinner together, 6 of us. DeWitt Wilkinson, one of his good partners and colleagues, with David Newkirk, one of the instructors, and Joan Forrest, and then Pete and my wife. And we had a great, wonderful dinner. It will never be forgotten. And I just really honor those colleagues that are really upholding some fantastic light within our profession. And one of the things that I recognize, a lot of people wonder, well, what did you talk about? We really honestly talked about how we can bring our profession closer together. That was the question that DeWitt Wilkinson asked me that dinner night. It wasn't about philosophy, because we recognized that we all have our own philosophies. They weren't going to sway me one way or the other, and I knew that I'm not going to sway them, because we live our lives and practice with conviction. But the time was just really wonderful. Pete was you can see, as a wonderful father figure, and we were all very humbled by each of us. And then when I went a couple of years ago to Chicago, I saw John Cram, and he reminded me of that dinner time that they all heard about. And I saw Joan Forrest, their head that runs the Dawson Academy. And again, she reminded me of the wonderful time, and we exchanged wonderful words. And the thought was bringing our profession together. That to me was really what hit home. And that's what I've been trying to help with in our dental community as best we could.
Well, humans are complex, and they're not, they need to be together from A to Z. I mean, you can't even get a dentist to agree that amalgam lasts longer than composite. And if you can't get them to agree that, then does evidence even matter? I mean, you can show them 100 studies that show amalgam lasts twice as long as a posterior composite, and they'll say, well, not in my hands. Do you think of all the specialties, do you think occlusion has camps the furthest away, or do you think there's other specialties that are more opposite?
Well, my arena has always been in this interesting topic of occlusion. I know it's been very emotional and heartfelt by many that really get into it, because it comes down to how do we relate the lower jaw to the upper jaw with our patients. What about the bite? And whatever materials we want to put between those top and bottom teeth, that's a whole different interesting discussion. But, my interest was always in that area of occlusion. I know it's been a hot topic for over 100 and some years. And what really hit me was when I came out of dental school, when I was in dental school, I was delivering a 3/4 gold crown, one of my requirements at Loma Linda, where I'm a graduate. And I remember doing that first crown and putting it in, and the patient came back and he says, my tooth feels like it's aching a little bit. And instinctively, I said, well, there must be a high spot. So I started looking around for the high spot, and I found it. And I relieved that. And for the very first time as a dental student, having that response from the patient saying, wow, that feels better, was a huge epiphany, realizing slight highnesses in the bite that would throw the patient off could cause a toothache or a sensitivity or some, odd feeling. And to me, that always really hit home as a new beginning dental student, and it launched my thinking into my whole profession to this day.
What I love most about the occlusal camps, I don't care what camp it's from, it seems like any dentist that wants to go learn more about occlusion gets serious about dentistry. They're no longer thumbprinting in an amalgam and taking a mush bite for a denture. They actually turn into dentist scientists.
Yes, occlusion is really an interesting subject because you can't see it. You can't see it on an X-ray. You can't really grasp it because it's not on an image. It's not on iCat, not on cone beam. You can't see it necessarily on an MRI. You can't sell it because no major company or sponsorship can basically put a hand on it, because it's not a product. It's something that actually relates, and it's actually physically within the confines of the oral cavity. Only the dentist has control of that relationship between the upper and lower jaw when they need to. And it starts back from early childhood development, when the teeth begin to evolve and how the lower cavity begins to form. And then the teeth sprout in, and they become part of the alignment of how the arches are developed, and the vertical dimension and the anterior posterior. All these things in 6 dimensions create the lower face and the jaw and how we breathe and function. So I find that a very interesting thought. But years ago, of course, I was very mechanically oriented. We were all into the hinge axis concept and articulators and face bows and all these things. And I just wanted to know, how can we do great dentistry? What can I do to be much more precise, more predictable in when I'm delivering my dentistry? And I did a lot of equilibrations back then, and I was searching for an answer of how we can bring and relieve some of the masticatory muscle problems that my patients were having, like headaches and neck aches, and joint derangement problems like clicking and popping. And that always was interesting to me. So that's kind of like the starts of my questioning of what was happening within our profession, just seeing what was happening in my own clinical practice with my patients.
So you graduated 1 year. You graduated in 1998. 1 year. I was 1 year before you. How has occlusion changed, or did occlusion change in 32 years? How has it changed since you got out of school from the didactics of it?
Wow, I'll tell you, I have seen over my 35 years of practicing, a whole profession has literally changed. Before, as you know, Howard, I mean, you mentioned amalgams. The dental school was performing amalgams, and now, coming into dental school, I remember doing composites. I used to work for Curtis Cybron Corporation, and we developed Herculite XRV as a former dental technician. And I saw the whole wave of light-cured composites and self-cured composites take hold throughout this profession. I saw all the different forms of small particle hybrids. And that went with me because helping develop some of the light-cured composite technologies, and the shading was part of my involvement. And then I got out of dental school, or I got into dental school, and there, you're trying to develop the skills to know how to basically do the dental things, from periodontal to tooth preps to fillings and root canals and all the things, dentures, all the things that we consider ourselves as dentists. And then after I began to get out of dental school, then you begin to start practicing, and then you realize the reality of what is important. What are your clinical skills like? How's your communication skills, and how to communicate comprehensive, quote unquote, dentistry to your patients? And I was practicing down in San Diego, California with my brother on the coast.
And you also in 2000 to 2006, which was, God, I can't believe how long ago, that was 13 years ago, you were the director of neuromuscular dentistry at LVI, which for a decade, LVI was the front dog of the whole cosmetic revolution. I mean, what Bob Ganley and Iva Clare and Bill Dickerson and LVI and you with that neuromuscular dentistry, that you three men, you were the three amigos of that whole revolution. I mean, it's Bob Ganley, Dickerson, and you. Talk about that journey and why did that and then later you opened up your own. But talk about the LVI years.
Well, I was practicing, I thought, great general dentistry down in San Diego with my brother Curtis Chan. He's also a general dentist. And so we were doing solo group practice. And I was just very passionate about this topic of occlusion, trying to do comprehensive dentistry and basically trying to survive and be financially successful. The bottom line is we want to be able to net well, not just have a large production. So I focused my practice on being very small, very unique. And I basically communicated a lot of these concepts that we now practice to my patients back then. But somehow I was on a Michael Maroon General 8 dental forum. They wouldn't get me off. I wanted to get out of it, unsubscribe to their program. But I kept seeing these emails coming through my computer, and I began to make a posting relating to occlusal concepts and joint arrangement issues. And I didn't know any of the players that were involved there. There's a lot of big names there. And eventually, sooner or later, I had an email from Dr. Bill Dickerson, who privately emailed me and was asking me about the questions. And in short, he eventually invited me out to the Las Vegas Institute, to which I never even heard of. And long story short, he invited me out, and I presented the concept that I was practicing. I asked him to come to my practice, but I knew he was very busy. So they arranged a time that I would come out. It was in October, I believe, October 9th, 1999, when we had that interaction. I came out and I presented the concepts, and then from that point, it evolved into being part of the program. I moved my whole family out to Las Vegas to be part of this process, mainly to convey a neuromuscular concept that I was very passionate about. And I called Bob Jenkinson, my mentor, who's the main guy up there, who is a fantastic teacher, and we collaborated together to come to Las Vegas to present these concepts to this institute. And for that, I'm very grateful to Bill. He really helped us convey the message. It spread like wildfire, and we pretty much capitalized on that opportunity because Bill was a great marketer, conveying a concept that really has been around for many, many years with the science and objectivity. So we felt pretty strongly about it. We knew it would wake up the profession. We knew it would shake it up on multiple levels. And I think many of the ducks that were in order, we were willing to take on the bombardment of questions. And for 4 years, between 2000 and 2004, I had nightly emails after emails from just about everybody asking questions. And we were in the fray. It was like this big battle of philosophies. But, now after all these years, I recognize, as far as I'm concerned, there is no war. There is no battle. There might be some in some people's minds, but in my mind, that the evidence is overwhelmingly there for those that have interest to find it. And I think I was very proud of the fact that to see this change. It became evident when I spoke at the Chicago Dental Midwinter meeting this past year. And from my understanding, I was the only one that was speaking on the topic of occlusion and was chosen to speak there at that meeting. On that roster, you couldn't see any other topics on occlusion, but I spoke on G&M occlusion, and the rooms were packed both in the morning session and in the afternoon sessions. And it was very intriguing. You see a lot of older gentlemen there, a lot of older doctors, and they were all very respectful, just listening to the message, because I believe that what we have makes sense, it's logical, and it's just very clinical and it's real.
So what
kind of what I saw happen over this period of time, huge changes in thinking about where the jaw joints are, how it works. There is much more greater awareness about the musculoskeletal signs and symptoms and TMD issues. And that's kind of the thought that I try to bring to light within a person to wake the doctors up. It's more than just bites, how to put teeth together in some kind of habitual occlusion, but there's physiology to this to get reliable, consistent results.
So let's cut right to the chase.
Sure.
These kids just got out of dental kindergarten school, and a lot of people throw dental schools under a bus because all the kids didn't learn all those things. Oh my God, I'm amazed they taught them everything they did in 4 years to give them a license and turn them loose, and they don't kill anybody. So I want to first start out with the journey. She just walked out of school an hour ago. She just got a job as an associate. She knows what she knows. She doesn't know what she doesn't know. What should she worry about the most? What does she need to pay attention to so that she can learn from you, so she has to stick her tongue in a light socket on a case or two? Where should she start this journey?
Well, the dental journey is a dental journey. When you get out of dental school, we don't know everything. But one of the basic things I think every dental student has a desire to is that they basically can make some money. You have to be able to be successful to pay the bills, let alone the big, huge dental bills that a lot of dental schools are coming out. But so they need to acquire some basic skills in doing basically normal everyday dentistry. You have to understand that. Being able to look at your patients, understand periodontal considerations, and how to do good quality basic dentistry, fillings, aesthetic dentistry, and then learn how to do some great cosmetic dentistry, very simple in a normal everyday bite. I think that is a fundamental for every good dentist, to have those basically those skill sets. And then as you're practicing, be aware that there are signs and symptoms that as dentists, as you begin to get beyond just doing the fillings and making sure that the margins are good and your x-rays are great and there's no periodontal, once you get past that concept and understanding, you begin to look at your patients as much more of a human being rather than a filling or a crown or a root canal or an implant. But you begin to look at and listen to their concerns of what is really ailing them and what causes teeth to break, what causes teeth to become sensitive, and why do gums begin to recede. And those are some of the next level of concerns that as dentists we begin to look at for preventive reasons. Because when you do your next crown, or the next group of quadrants of dentistries, or your next group of veneers, what assurance do we have as clinicians that it's not going to break? And you then have to begin to realize that muscles underlying will take hold of the mastoid system and create a lot of havoc that we see in dentistry. And that creates the perpetuation. The unknowing creates the unknowing of what to do. A lot of dentistry is being performed out there. Insurance companies are there to help support some of that, but we recognize it doesn't cover getting the patient 100% healthy. And so as dentists, it depends on your philosophy of what you want to do as a practitioner. If you want to do drill, fill, bill, that's one way, and you can be a great dentist being very successful at doing that kind of dentistry. Then there's another group of dentists that basically are looking at how to be more comprehensive in their skill sets and how to diagnose better, to have longer term stability of your cases, not just that fillings and crowns don't break, but how do you get the whole stomatognathing system, the facial system, the neck, shoulders, and the head musculature that are part of the jaw mechanism. How can we get that stabilized so the implants don't fail, or we don't have a recurrence of need for further root canals and for pain problems that we didn't understand? And how can we resolve these things that relate to the bite forces? And so this is kind of like the evolution of the dentist. So from the beginning, doctors that are learning, get some basic skill set, take courses out there to help them understand, how to do basic everyday dentistry. And then when you're ready to move up to the next level, then take some courses on what does dental occlusion really mean, and listen to all the big speakers out there. There are fantastic lecturers and teachers, and I'm sure eventually you will find your way at our program, Occlusion Connection, sooner or later, because you're going to be comparing notes and seeing what actually makes sense.
So Dental Town, there's always, there's 50 sections on Dental Town. You mentioned Mike Maroon,
Yes.
Generation X. He was the pioneer for this format. He was my mentor, brainchild. I saw what he was doing with Generation X. I thought he was amazing.
Yes.
But on Dental Town, one of the forms is TMJ. It's the last one, just because of the T. But here's the post for today on Dental Town, which already has like 100 replies. This guy has 7 questions. He says, number 1, is there any kind of general agreement on a definition for TMD?
Well, in the TMD world, it really comes down to 2 basic philosophies. There is the one and the main group, which comprises many organizations that of whether it's centralization or of neuromuscular philosophy, but it's more of I call it a biophysiologic based neuromuscular biophysiologic based concept that they recognize that the bite does relate to some of the TMD symptoms, the mastoid muscle pain problems, headaches, neck aches issues. And then the other philosophy is more of a psychosomatic philosophy, where they basically don't really espouse so much that the bite or the occlusion has a lot to do with it, but more of an emotional stress factor. And they want to basically manage the pain syndromes through either medications or other modes of therapy to manage the pain cycle. So those are 2 different methods by which patients are recognizing where they go.
So is psychosomatic or what?
Psychosomatic, psychosocial versus a biophysiologic philosophy where doctors recognize that the jaw, the relationship between the top and bottom teeth relate to a lot of the pain symptoms that actually a patient can experience.
Okay.
So these philosophies, one fits really well with the pharmaceutical companies because you basically just sit there and write prescriptions as if you're going to pacify that serious pain problem. And then there's another group of doctors, which I'm more of that belief, is that if the bite is off and if there is high proprioceptive occlusal interfering problems, it can trigger muscular strains, lateral pterygoid problems, clicking and popping in the jaw joints, as well as neck issues. And this is really what we find interesting within our profession.
Just to finish off that, so she just lost her job. She's credit cards max. She just got a divorce. She just found out her
Yeah.
kid is going to go to U of A. Is there any psychosomatic component to TMD?
Absolutely. There is definitely, I would say, most of the TMD, even from research, we found that 80 to 90% of these TMD, temporal mandibular joint dysfunctions, are really muscle-related problems, bite muscle problems. Of course, the joints are involved. But when the patient is not able to find a good remedy or a resolution to the problem, it does turn into psychosomatic issues. You get very stressed, you get depressed, anxiety kicks in. All these factors are very real. But I would say that that is in general, a 10% problem relative to the bigger picture of what patients have as far as TMD problems. Most of these TMD problems I see in my practice, uniquely out here in Las Vegas, patients fly in from different parts of the country and wherever states to see us. But they all recognize that there's some jaw bite problem from either previous dentistry, orthodontics, or something happened in their full mouth rehabs, and that their muscles are paining. It's just killing them. And then very rare do I say, oh, it's a psychosomatic problem. Let's just get over it. Even though you got a bite problem, you got screwed up in your full mouth. So just get over it and get used to it. That's not going to happen. So we have to go search for that. And then these patients become very sensitized to what goes on occlusally. They don't know it necessarily, but it can drive them pretty crazy. And so then it leads to what philosophy is going to remedy that kind of problem. Those are the ultimate challenges I find that will press any clinician as far as your philosophy and skill sets of how well does your philosophy handle those complicated cases like cervical dysfunction, anterior bite problems with pain, class 2 division 2 retrognathic problems, and then true TMJ joint derangement problems. And so what philosophy will handle that? So, the new doctor that's coming out, has big paying bills. I think, some of these pain cases are going to take a lot of time, and you don't really want to be involved in that necessarily as a new dentist, because you got to keep the production rolling, because some of these patients will take quite a bit of your time. So it's either you have to charge adequately for your awareness of what that problem is instilled, or make the proper referral. If you don't have time to sit and take time to take and deal with each of these patients that can take some time, then you need to know where you can refer them to effectively get the job done. And I find that a very interesting fact of these patients are going around the country. There's a lot of millions of people like this, North America, Canada, they're all over our profession, and they don't know where to go to seek and find that help. So they go from doctor to doctor. Everybody has an opinion. Everybody has a technique. Everybody has a splint, an orthotic, or some method to pacify the situation. But eventually, the patient will get tired spending a lot of their money, and they're going to find where it's going to could be a dead end for them. So this is very frustrating. You can see that on Facebook, for example, a lot of TMJ groups out there, and these are lay people that are searching for an answer. And a lot of them have been pretty well lamed and maimed for various reasons, but not intentionally by their doctor, because all doctors have a good intent typically, but they couldn't seem to resolve these difficult, problematic cases. So either our profession says, you're whack, we don't know what's wrong with you, so you become part of the waste heap of our profession, and we just don't want to deal with it. Or, recognize that these people are real, that there is a real problem, and we just didn't have the nuances as a profession or know-how to understand what was really going on.
So again, I am really interested in your journey. So you started out with your brother Curtis in Del Mar.
Yes.
And that must be so fun. I could just, that'd be so cool working with your brother. And then you did the LVI years, and then you started your own years ago, Occlusion Connections, where it seems like you've gone from neuromuscular, where it's NM dentistry, to put a G in front of it. It's silent. I don't know how to tell you on the radio, but neuromuscular with a G. So gnathic plus neuromuscular. And the only thing I know about gnathic is it's Greek. It's the Greek word for jaw. So
Yeah.
why did you put a G in front of neuromuscular? And what does that G mean to you?
Well, I was pretty much raised, you might say, evolved early on in my career as a gnathologist. I had a great teacher, Dr. Philip Taylor, who taught me fantastic occlusal concept. It was all heavy duty, uppermost, rearmost, central relation, but it was a really fine approach to understanding how some of those things worked as far as jaw joints and jaw closing, and specifically the precision in how we would adjust our bites. That's where I really got a lot of influence in that gnathos, the study of the jaw. We were really more influenced by Charles Stewart and B.B. McCullum, some of these great gnathologists from Ventura and the San Diego area. But then as we evolved, one of my students, after I resigned from the institute, says, you're really a gnathologist and you've always been teaching neuromuscular NM from a gnathological standpoint. And he says, why don't you just put the G in front of the NM, since you have resigned from the former institute that was espousing a form of NM. And he says, I think that would be a better way to blend the process. And I thought that made total sense, because I am a gnathologist. I am a neuromuscular doctor. I believe in both philosophies. And that's how we evolved with the gnathos and the neuromuscular blending together. And that's really what I've been practicing for quite some years now. And that's what doctors come to want to understand. What is it that they're missing in their occlusal or TMD philosophy?
So the reality is that of the 150,000 general dentists out there, if someone has any problems with anything to do with TMJ or whatever, probably 90% just do a FA for a night guard, and someone comes in and does the insurance arrangement for a night guard, then they leave, then the assistant comes in, takes alginates, and makes an upper, just a splint, and that's how it's done 90% of the time. So she just graduated from dental school. She became a dentist because she wanted to be like her mom. Now she's in this family practice. That's how her mom teaches TMJ. And she's sitting there wondering, is that how you stabilize patients with masturbatory dysfunctions? And is that how you do it? Is that what you do to start? You just take alginates and send it to the lab and make an upper splint?
Well,
do you agree or disagree that that's how the majority of it is treated?
Yeah, I remember, in dental school, they don't teach you how to find the proper bite-jaw relationship with patients that have jaw dysfunction problems. If your patient has clicking and popping in their jaw joints, just asking the lab to take upper and lower impressions, I have some models here, and then just opening up the incisal pin 2 millimeters and make some kind of appliance is not necessarily going to work all the time. You're going to end up, guess where, grinding when you deliver that splint or appliance. You're going to end up grinding often in the second molar region. So the question is, why are we having to grind in the second molar region? It's not because the lab screwed up, but it's typically that we as dentists never recognize the other dimensions, the pitch, the yaw, the roll dimensions, or the decompression aspects of the jaw joints that were dysfunctional. That when we just ask the lab to open up the bite and you make a splint, it's only going to be fitting to that relationship. When you put that splint into the mouth, naturally it's going to be high if the condyles and the jaws are up and back. So in order for me to be much more consistent and reliable for my patients that come in from wherever, I don't have time to be wasting time, and they don't have time to be wasting on me, because we charge a pretty good hefty fee, but they want something precise. So when I take my bites to a new graduating student, I say, hey, pay attention to how your patient's jaws are talking. When the patient is talking with you, they're not talking in some kind of retracted position. When they're speaking and their front teeth are opening and closing, watch that anterior-posterior relationship. Look at the frontal relationship as they're talking with you. And then when you then say, hey, bite your teeth together, typically the jaw then goes back. But that's not the bite you want to build to. You want to build or construct the splint to a much more physiologic, relaxed position. And you can see that. But oftentimes, we think that the jaw joints are the focus on how you're going to get the proper jaw relationship. And I'll tell you, it's not, specifically when you have dysfunctional problems, bent condyles, beaking, sclerosing, all this osseous degeneration. We can't, as a profession, rely on those pathological conditions to restore something physiologically back to health. So ask your patient. I've told our doctors, even in our Chicago midwinter meeting, take some cheek retractors, break up the proprioceptive ingrams of the jaw, and watch to see how that lower jaw and the teeth relate to one another. And you'll see that oftentimes people that have joint arrangement problems are going to naturally flower slightly forward, not in this prognathic position, but in a slightly more relaxed position, and facial form is going to look prettier too.
So on the Dental Town thread, it's kind of interesting. He said he's got 7 questions on TMJ, and this thread's exploding. The first one was, is there any kind of general agreement on the definition of TMD? You answered well. His second one, is there any agreement on a set of conditions, signs, symptoms that is considered diagnostic for TMD, which is exactly what we're talking about. She came out of dental kindergarten school. What clinical signs and symptoms should she be looking out for?
Well, there are a number of them. And see, this is where it's so amazing that the dental student is fresh with their physiology. They're fresh with their anatomy. And if they can then relate what they just recently learned, they took their state boards, for example, on, the muscles of mastication. When we do an examination for muscle palpation, we should consider this. And I'll ask the question to our young colleagues. When the temporalis muscles are tender, what does that mean to us clinically? When the mastodory muscles are tender to palpation, what does that mean to us clinically, occlusally? When your SCM muscles are tender and they're not feeling too good, or anywhere around the head and neck or the jaw, when these muscles are tender, it should mean something clinically to us and not just to forget about it. So let me give you a couple little tips for our young colleagues. If your temporalis is tender, what that means is that the anterior-posterior relationship of the jaw is slightly off. It's basically functioning slightly posterior to really where it should be. If the facial muscles are tender, it tells you that the front teeth are hitting slightly prematurity more than the back teeth. Think about that. When the occipital muscle back here, or these muscles, it all relates back to specific things on the teeth. That's how I kind of convey it even in our level 1 course at Occlusion Connections. And all of a sudden the lights go on and say, wow, this is what muscle palpation means to me, because we were, as dentists, trying to be comprehensive. Our patients are laying there with our gloved hands, and we're going through this muscle palpation process, and we have no understanding what this means, right? We just write this down as tender here and tender there, and then on with the show. Let's go ahead and find the existing conditions of where the deficient margins are, what's broken, and where's perio. But we don't have any relationship of what this meant. And in dental school, we should have emphasized when muscles are not comfortable, when they're tight, when they're showing some tension, that means that the whole lower jaw mechanism is not totally neutral. That means the occluding positions of what's presently there is not necessarily reliable anymore. So adjusting the bite to that existing position only will enhance the tenderness of these abnormal muscle problems. So that's just the beginning of how some of the signs and symptoms relate. There are many signs and symptoms that we show our doctors, a whole list of things like headaches, TMJ pain, limited mouth opening, ear congestion feelings, vertigo, loose teeth, clenching and grinding are all some of the many symptoms that relate to unresolved or unhappy muscles of your patients that will relate to tooth strain, tooth breakage, tooth sensitivities, stuff like that, which then perpetuates the dental cycle.
Okay, the number three. You care if I just keep going on this list? Says, is there on this list of 7 things? She says, the next one would be is there any diagnostic test equipment that she needs? Some people like you talk about myotronics. Is there what TMD equipment does she need?
Oh yes, yeah. I mean now, first before I make this next statement about equipment, I'd say first the dentist needs to be astute on their diagnostic awareness, just as a human being, understanding how jaw muscles, jaw joints, and relate to the jaw relationship. That is fundamental with whether you use instrumentation or not. Just having that diagnostic awareness of jaw relationships, that there can be a better jaw relationship if the patients are having these symptoms. All right. Now, from an objective standpoint, and this is where Neuromuscular NM shines, specifically with the myotronic technology that I specifically use and endorse. The objective technology allows us specifically, and I'm going to emphasize it this way, that we're able to see from a physiologic standpoint using low frequency TENS and involuntary jaw relationship, not a strain relationship, an involuntary movement. And we can see that by jaw tracking it. We can see that on our computers without touching the patient sitting up. You can actually physiologically see a jaw position in space in 6 dimensions, I should say at least 3 dimensions, sagittal, frontal, and vertical. And you can see where that jaw would like to be without forcing the jaw. And the way you see that is with low frequency TENS, where you actually get a stimulus of the jaw that creates a involuntary movement of the jaw, and that involuntary movement creates a pattern that's consistent that you can actually see the frontal AP frontal-lateral relationships. Now, most doctors that are hearing technology always hear the emphasis on EMGs. Well, I'm gonna put this to bed here. EMGs don't take a bite. EMGs does not relate the lower jaw to the upper jaw physiologically, but you do see muscle activities. So when we are listening to the word neuromuscular, in our occlusion connection philosophy, we emphasize to our doctors, understand what the low frequency TENS does to find the jaw relationships, and then you can track the jaw objectively without manipulating the jaw in a physiologic manner, and you can see the difference between habitual closing patterns versus physiologic closing patterns. And that, to me, is the essence of why I do what we do and teach, mainly emphasizing that part of gnathology with the neuromuscular instrumentation. And then we will then layer that later on down the line with what does EMGs mean, meaning that it can monitor muscle activities, and you can see if the muscles are hyperactive or low, but you compare that with tensing before and after. And therefore, then it gets into a lot of diagnostic concepts. Another aspect is using electrosonography, where you can actually monitor and measure objective joint sounds, vibrations of the patient that has dysfunctions. So these are 4 devices. You have the K7, which is the kinesiograph type thing with the sensor ray. You have the tensing, which basically creates the stimulus of involuntary movement. And then you have EMGs that measure muscle activities but doesn't take the bite, but it gives you some nuance of what muscle activity conditions there are. And then electrosonography is a 4th diagnostic tool that I use in my practice to decipher the subjective concerns versus the objective things that I see. And then we want to blend that together and make sense out of it.
And what's the difference between myotronics and Texcan?
Well, Texcan is a recording device that was endorsed by another competing company. Texcan is basically a digital wafer, and I'm not an expert on Texcan, but it's a digital wafer that basically allows the doctors to see high-low spots in their mouth. It is a wafer about 100 microns thick, but of course it has many sessels that are the sensing devices within that digitized wafer. And the patient basically can pretty much bite down in their existing excuse me, in their existing bite to find the high spots. All right. I'm not an advocate of that because when I'm adjusting my bites, I don't want to just have the patient bite down in a habitual, voluntary manner to clean out high spots. I want to find the physiologic jaw relationship. So we use different parts of our K7 to find that more physical position and then refine it with what we call a scan 12, which is a high-low chart pattern, first tooth contact at probably between 10 and 20 micron levels of detail.
So what would be her basic, you said training first. You want to educate your brain. The last thing you want to do is hand someone an MRI that doesn't know what they're doing. What would the basic equipment from Myotronics be to get started in this?
Howard, it's very simple. I think all dentists that are going down this occlusal route should have a fundamental TENS unit. Specifically, I would advocate very strongly, specifically the J5 monitor or the J5 dental TENS unit. The reason why this TENS unit is so valuable and has been heavily underrated within our profession is because, well, number one, the J5 TENS unit basically gives an involuntary movement, a tapping sensation that breaks up the proprioceptive ingrams. It's not there to relax muscles, although it can do that. But it breaks up proprioceptive ingrams of jaw positioning and jaw, resting characteristics. This way, I don't have to rely on joint conditions to determine my rotational and translational closing paths. So the TENS, I think, is a very simple device. It's not that expensive when you consider the overall bigger picture of how much dollars we spend in technology these days. But the TENS unit is very key from Myotronics. Number one, because it's FDA approved, but specifically it's designed for dental use. It's FDA approved for dental use, not just medical use. And the reason why TENS is very valuable is because it allows you to find jaw relationships, master muscle dysfunction. It's also to break up proprioceptive ingrams, and it basically helps you deal with Team J issues as far as, these things that we've been talking about. So to me, TENSing is invaluable to what we do as G&M doctors.
Okay, and again, she's very confused because her mom's her idol, and if she's working with her Monday through Friday, 8 to 5, and if they do any filling or crown or anything, and then the patient comes back and they're sore, everybody just has them bite down on some paper and smooth it off till it doesn't hit anymore.
Right.
What does she need to be observant about? Occlusal wear? She's it's tough because she's confused. Her mom's her idol. And this is what her mom's been doing for 30 years. And she's even in one of those fancy states like California. We're not talking Kansas or Oklahoma where you'd expect this. She's out in the fancy state, and this is what her mom's been doing for 30 years. How should she look at occlusal wear differently? How should she look at it differently?
Well, I was a resident of the fancy state, born and raised in the fancy state, California. Okay, San Diego gets pretty fancy, 6 minutes away from the beach, and I practiced 4 days a week there and surfed the remaining 2 or 3 days a week for 15 years. All right, that's fancy. All right. So when you begin to look at patients' bites, you have to consider: is this a paining patient or is this a non-paining patient? If the patient is not paining and they want a single crown or a single tooth, just go ahead and do that normal dentistry in that existing bite. Don't change anything. Don't go around and grinding up somebody's bite. That would be the worst thing you can do. But if in your conversation that the patient is telling you that they get tender muscles, and you begin to recognize that their opening closing path is really opening in a certain path, creating anterior wear facets or abfraction lesions, and you begin to see they hit and they slide back, and they hit and slide back, although they always will close on their back teeth to avoid the front hit. But you see the evidence of wearing of the front teeth and gum abfractions and buccal, wearing. You then have to rethink, what do I need to do in my conversation with my patient to convey to them that there is this wear and tear going on that relates to their clicking, popping jaw joints, and to what level is their need. If you find that the patient is not really concerned about it, you need to still record this and monitor it, mainly not monitor it, but basically let the patient know how it will impact the overall jaw condition and the long-term longevity of their existing dentistry, all right? Because it's going to, in time, slowly wear and create some havoc to their system. If they are coming to you and you recognize that they have musculoskeletal issues that should be fundamentally addressed before you did occlusal dentistry, then you need to consider, how can I relate the lower jaw to the upper jaw much more physiologically, so you don't have to repeat the process. So when you're now restoring this case properly, whether it's a quadrant dentistry or group of teeth, we need to know what is that jaw relationship in 6 dimensions. That opens the door for comprehensive level of concerns, and now the skill sets of the doctor astronomically goes up as far as what and where do I begin, all right? So the bottom line is, don't open up bites crazy. Just find a jaw relationship that physiologically fits the patient. You can use a lower splint for the beginners, right? And just watch to see what happens, but just I would say, do a lower splint. Don't do an upper splint, because the upper splints usually bring the jaw back. But do a lower splint that just realigns the jaw so the clicking and popping in the jaw joints goes away, so the muscles calm down. When that calms down, then you begin to then realize, now what do I need to do? How do I restore the case back so I don't have clicking and popping in my jaw joints? Or how do I rejuvenate the case logically in a systematic way without creating more muscle tension? So these are 2 types of patients that a young doctor has to be aware of. Majority of 80% of the patients, or 70% of the practice, are going to be with everyday patients that are just coming to see you for normal everyday dentistry. All right, that's fine. Just keep doing that dentistry that we learned in dental school. But then there's probably another 25% of the patients that are going to have these other signs and symptoms, but they don't realize that you, as a doctor, has some extra knowledge to identify what would be the better jaw relationship. And if you can begin that conversation, that you see there's a better jaw relationship for them, then you need to find out, how can I acquire that for them and stabilize in that way. Specifically, if they got deep curvous speed, worn down dentition, missing teeth, these things you can't just let go and just say, oh, everything's hunky-dory. Now, if the patient doesn't value that, then just let them be and carry on doing normal dentistry. It's not about hooking them up with a bunch of wires and tensing every patient that walks in the door. It's about being conservative, being reasonable, and respecting your patient's feelings.
I'm just curious. I have to ask. I live in Phoenix, and there's 3.8 million people, and every single one of them wants to live in San Diego. What caused you to move from heaven to Vegas? I mean, Vegas is, well, I was wondering, because is a big part of reason to go to Vegas. I mean, the ADA has pulled dentists for as long as I've been a dentist, and Vegas is always the number one choice when you ask them. Did you stay in Vegas because it's a better dental continuing education landing place for your institute, occlusionconnections.com?
Yes, Howard. I've been as a former surfer. I love the beach. Oh my goodness, I love the beach, and I like the ocean air. I like surfing in general, but when I found an opportunity and was asked to come to present this neuromuscular concept out here, I have been on the most amazing dental wave ever in my life. And that surfing of this wave occlusally has driven me to appreciate dentistry on a whole different level. And because Las Vegas has been such a great location for fly-ins, great flights, it's a great destination. It's hot out here, all right? But the location, the infrastructure for hotels and supporting is a great venue. Now, our teaching is a very small teaching entity, but I believe we make a huge impact. You don't have to be big to make a huge impact profoundly in our profession. I found that out, all right? Secondly, the reason why I still live out here in Las Vegas is because I found that the type of practice I have is very unique, in that in fact, all my patients, I don't have a patient of record here in town over the last umpteen years. all right? Not a patient of record, but I've been able to survive because of what we teach, what we are practicing, because we practice what we preach. And all my patients from pain problems and whatever fly from either out of the country or out of state, North America, whatever, and they come here because the city is able to support that process. They don't come here for gambling. They're not doing some crazy stuff out here, but they mainly come specifically for treatment and our philosophy. So that's really what we do here. And that's one of the reasons why I stayed out here. Sometimes being out in the desert allows you to recontemplate many, many things in life. And you consider what is valuable and important. So for me and my patients, finding the right bite is really very valuable, specifically for the type of dentistry we do. All right.
You know, I'm looking at your courses. You have one, Advanced Principles of Physiological Occlusion, Level 1. The next one, this is September 4. Your next one's October 10, 11, 2019. And then you got Advanced Diagnostic Principles, Level 2, 3. Then you have Introduction to Micro-Occlusion, then number 5. But anyway, you have all these courses. And you know what I really think you should do? Because I listen to my homies. They email me, howard@dentaltown.com, or they put comments on YouTube or whatever. But the Panky Institute did something which I wish you would do. They went on Dental Town. It's hard to go from, I've heard it, all the way to flying to Key Biscayne. So they did the Panky Institute did a series of online CEs where they said, we're going to do a 1-hour class for each one of our weeks. So Erwin Becker and all those guys, they did 4 classes for 4 of their week-long continuums, and they said it bridged the gap. So for her to sit there, she's in Fort Scott, Kansas, and she's like, okay, I'm supposed to go to Vegas for 2 days. But if she could hear you for an hour on an online CE, that would help her. My job as a leader is trying to get her to motivate her to go. But my gosh, some of this stuff. And then orthodontists. I wish you'd make one. We own OrthoTown too. We got half the orthodontists in America on that thing. Orthodontists are always thrown under a bus that for the beauty they blow away the curve of Spee and Wilson and they're not good in occlusion. And a lot of dentists say, when I get these patients back from the orthodontist, it's like they're not impressed. Is that a bad rub, or is that a real thing?
You know, I think as dentists, we have to be respectful to all our colleagues. I don't like to badmouth our colleagues because they're doing exactly what they were taught and trained to do. Orthodontists are there to basically treat and align teeth, malaligned teeth that have that problem. And I would agree with you. As all of us, we weren't taught the concept of how to relate the lower jaw to the upper jaw physiologically and bring the teeth properly together to harmonize and support the overall body posture. Let me make one point. The occlusion is not just teeth connecting, but occlusion is really a means that nature has instilled in the body's mechanism to help support long-term proper postural stability from head to toe. That's what occlusion is. If you have malocclusion or lack of supporting bite structures, basically your jaw joints begin to collapse, your discs begin to anteriorize, your head and neck begins to become forward, your hips begin to rotate forward, your knees begin to roll in, your feet begin to become flat-footed. So orthodontics should be considering not only the orthodontics, but the orthopedic development of the jaw. And this is one of the things I find unfortunate, that most orthodontists don't understand the verticalization orthopedic aspects of how we get the jaw and the disc and the joint derangement problems resolved. Now, in young kids, it's easy because they're so adaptable. Anything is going to go, all right? But in the adult problem now, when adults have good, relatively decent dentition, they don't have a bunch of crowns, they need some orthodontics as an adult stage. But those are becoming much more complicated procedures because it's not fast, but we need to grow the bottom teeth up orthopedically to support the collapsing jaw joint and the disc issue. So that is what I consider orthopedics. I do orthopedics. My patients come in with orthodontics with Team J problems. and we basically help them with a orthopedic concept of how we can help them get out of the pain problems and still have good, looking teeth and smiles.
So when you talk, when I'm on your website and I'm looking at orthodontics and dentofacial orthopedics.
Yes.
What's the difference between orthodontics and dentofacial orthopedics?
Well, a lot of this is terminology, all right? As far as I'm concerned, orthodontics creates the straightening of the teeth. And yes, some orthodontics will say, look, we have great smiles, all right? But here is the next part. We want not only just great smiles and great looking teeth, not only just great looking profiles, but we want function. We want jaw joints that are dysfunctional to be functional again. We don't want clicking and popping problems. We don't want airway problems. We don't want breathing problems after. We want long-term stability. Here's my thought. Why do orthodontists routinely give their patients retainers or lingualized retainers? Why? Because we know as a profession, teeth begin to move again. Why are the teeth moving after orthodontics was performed? What causes the teeth to move? And I say, because the teeth weren't put in a neutral position where the mastoid muscles and the tongue muscles was neutralizing with the proper bite. If you can find that, then typically, ideally, retainers aren't necessary to be there mechanically. The body should retain itself. The tongue should be retaining the arch shape. The occlusion and cusp fossa form should help retain that arch shape. Proper breathing should create that retention. And all those things mastoid muscles are all helping to support that orthodontic correction. But if it's not properly addressing the correction properly, if they're not stabilizing it, then things are going to collapse and it just goes right back to away. So retainers, I guess. You're just masking the problem.
Not to get too controversial, but we do call this Dentistry Uncensored, so it leaves me an out. So does that, we were talking about orthodontics. Orthodontists, you don't want to bash them or anything. But now Smiles Direct Club is going to do an IPO very soon, probably within a month. What are your thoughts on that? Do you think this is a good thing for America? Do you think it's an innovation, or does it concern you? Or where's your thoughts on
Yeah, I'm not very familiar with orthodontics direct, whatever you mentioned there. I'm not sure what that is all involved. So you could have to fill me in a little bit more about that. What is it that you?
Well, it's a play on teledentistry. So you would go to somewhere, someone would scan, they'd send the scan to someone,
Okay.
they'd make so you get Invisalign without having to see an orthodontist.
Okay, I see what you're talking about. Look at digitized dentistry is fantastic. 3D imaging, all the stuff is technology is evolving. But I don't believe that it's going to ever take away from the need for clinical dentists to make the final decision. They're going to have to be the actual treaters of this thing. You can digitize and robotize all you want, but it's going to take the human touch, I believe, that's going to have to make the ultimate decision of what arch shapes are going to supposed to be. How are you going to deal with the breathing thing, the proper mouth breathing, the tongue posturing problems, the abnormal swallowing patterns. Digitized dentistry can't address those factors. They can't address necessarily the joint derangement issues that we as clinicians need to be very aware of as treating clinicians when we're doing our regular dentistry. So there's a place for it all. It's part of the evolution of dentistry. This day and age is very digitized, many years compared to previous years that I've been in the past. But again, as dentists, we easily get distracted by all the things that are dangling us and the things that we see at big conventions. These things, we think that's dentistry. But I'm saying, no, those are the things that are being sold to us as dentists, but dentistry is really in the dentist. It's their understanding and the need for our wisdom, our understanding and skill sets to be the true physicians of the mouth. That comes from here. And then we can apply these tools of the trade, the technology, with our know-how to treat the human being properly.
There's another thread, and I wish it's under prosthodontics. And these lab guys basically saying articulator. It's the tools of the trade for success. So again, this little girl, she's 25. She's pregnant with her mom, who's as old as we are, and
Yeah.
her mom hasn't used an articulator since Mickey Mouse met Minnie Mouse. Does she ever need an articulator? When does she need an articulator? Is it okay that her mom does all these big cases and has never used an articulator?
Well, you know, that is a great point. I used to, I'm very familiar with articulators, all right? Face bows and hinge axis, the whole 9 yards. The human jaw is the best and most reliable, you might say. The human jaw is the ultimate articulator. All dental mechanical articulators are trying to simulate the human jaw. But I don't think that there's any one articulator that actually simulates joint derangement problems or disinterference disorders or these kind of things. And so we see that the articulator is just a device to hold the upper and lower models together. So I call them, in articulator, a great model holder, all right? So on my articulator, I lock all my incisal pins. They're all epoxied shut. I don't have adjustable pins. For me, the least moving parts on any dental articulator, the better. I don't even worry about articular eminence. Now that sounds crazy, but I don't really worry about articular eminences anymore. I used to, but all my patients have joint derangement problems. One side is different than the other. So should we use articulator? Sure, but then go ahead and mount it at least reasonably to at least simulate an opening and closing jaw closure path properly to hold the bite to then create the proper wax up or the proper device that you're trying to fill in intraorally that's deficient vertically. That's all I use the articulator for. I don't use it to simulate jaw lateral movements or all these things that we as dentists got into believing, because no articulator is accurate enough for a patient that is live and has joint derangement problems. But again, I have articulators in my practice here, but I don't use them for those reasons. All right? It's how I take the bite and how I adjust the bite in all the gnathic movements. That's what the articulator doesn't do.
So now are you ready for me to just get you in trouble with everybody? So again, I'm not an orthodontist, but I do own the orthodontic community, Orthotown, and send them all a magazine every month. One of the most trigger words you can say is orofacial myofunctional therapist, and at least 90% of the orthodontists are anyway. What is your thought on orofacial myofunctional therapy?
I've never heard of it in that in that manner, but I do believe that there is myofunctional therapy. I believe that there is some validity to it as far as getting the tongue to posture properly. Dr. Wing Chu in Singapore has been a very strong advocate of that. I applaud him for that. To me, he's the new up and coming Jim Gary as far as that motivation drive, as far as oral development. And so I'm all for having the tongue properly postured and functioning, because if you have tongue tie, that needs to be cleared out, because you do need, the human being does need to have a normal tongue that functions. Because if you don't have a normal tongue that's functioning with a normal swallowing pattern where teeth are bracing properly together, I don't believe that tongue should be posturing and swallowing with their tongue between their teeth, like some others that believe that it's normal to have tongue between your teeth. But from our jaw tracking technology and what I understand as stability, no, tongue between teeth is only a shim that's shoring up a deficiency in the oral pharyngeal airway space that's blocking normal tongue patterns. If the oral cavity is normally developed both vertically in the back, transversely, and AP-wise, there is no reason why the tongue or the tongue should be between the teeth when you swallow. Teeth should be bracing against their teeth normally, all right? Not that we're clenching and grinding all the time like that, but that oral cavity in the back should have sufficient space when you do the swallowing act where the tongue is not going between the teeth posteriorly, lateral tongue thrust, or the tongue is now having to be displaced anteriorly to create anterior bite problems. So we want normal swallowing patterns. So myofunctional therapy to me is great. Now, as far as oral, facial, whatever, I know there's some great advocates of that. Anything to get the case in neutral, I think is very important. But one thing they can't, the oral facial myologists can't always do is how to deal with joint derangement problems. Joint derangement problems, clicking, popping, displaced disc, no matter what, if you don't have that resolved, none of the oral facial, whatever tongue muscle therapies are going to resolve it until you get the proper supporting bite to help some of those tongue patterns. And then the orthodontics is not going to be stable without a proper vertical support in the back of the bite. All right. Posterior support is absolutely key to create proper joint health, proper disc positioning. So it's captured or recaptured or reduced, however you want to call it. These things are absolutely critical so the jaw can open and close properly, not just deviating to one side. And then having that proper orthodontic occlusal support will help to create neutralized muscles so the patient is truly stabilized. And the amazing thing is, in our arena of technology, we can define and quantify what truly is stable. What we mean by stable, it's not just a fancy term. Stable should be quality of good terminal centric contact, free of any interferences. Stability also means calm, normal musculature in both the cervical group, all over the head and neck. You should have stability in the closing path so it's nicely reproducible with no clicking and no popping. All right. And then the patient should be pain-free, off meds. All right, not pacifying themselves with stuff to keep them calm and comfortable. So the functional matters, I think, occlusally are quantifiable and are reasonable goals to get our patients happy and healthy.
We're 10 minutes over. Can I still got a couple questions. Do you need to run, or can I keep you in overtime?
For it.
Again, I want to talk about Dentistry Uncensored. I don't want to talk about anything that anyone agrees on. I want to talk about everything that I want to ask questions that upset you. And there's basically
go ahead.
There's basically a lot of people sleep dentistry that make a lot of claims about the relationship between sleep apnea and TMD. Some people say. There's one guy on Dental Town saying that that if you if you don't do a TMD workup on a sleep apnea person, he thinks it's malpractice. So succinctly, is sleep apnea and TMD, how are they related?
There is a correlation of TMD problems and sleep apnea. One thing I found though, this sleep thing, the wave, the whole profession has shifted into an awareness of sleep and sleep apnea. That really came, I have to give a lot of credit to Dr. James F. Gary, who was my former mentor. He passed away in 2004. He was the doctor that basically was a pediatric dentist that basically relinquished his license in California to go into GP dentistry because he saw the early development of his kids in his practice creating and developing malocclusion, all right, from lack of airway and proper tongue posture. And then it turned into full-blown TMD. So when you can't properly breathe, yes, you will clench and you'll grind, all right? And these things do happen. And of course, there are different levels of sleep apnea. There's mild, moderate, and severe, all right? I don't treat the severe kind. And in those cases that do have severe sleep apnea, snoring and things like that, with a lot of apneic episodes, then you have to work with a sleep physician and these kind of guys to help support what we do for intraoral appliances. But here's the rub that I see. The sleep thing, which was a great venue for many doctors to this day, because it's another financial venue for them and many, and there's nothing wrong with that. But if we say that all patients that are grinding and clenching is because it's a sleep problem, then I think we still miss the boat. Because I have many patients that have had plenty of sleep studies. They're normal as far as their airway issues, and they have gone to sleep, and they still are clenching, grinding. Then we have to ask our profession, it's not just giving the patient a sleep excuse. saying you have a sleep problem because you clench and grind, and that's, the problem. No, it's not. There can be other underlying factors beyond just the sleep, just beyond having a sleep study. All right, what happens if the patient already did a sleep study and they're not having their clenching and grinding resolved? Then we have to look beyond and find out what is the occlusal problem that is actually triggering this problem. All right, so I believe abnormal or normal swallowing patterns, normal tongue posture, normal as far as occlusal jaw joint stability. Let me make this statement, as I tell many of our doctors at our occlusion connection courses. When we understand the gnathologic and neuromuscular principles, you should be able to stop clenching, and we should be able to stop grinding. If you can't stop grinding, then you might be missing something in your gnathological and neuromuscular understanding.
Well, this has been so wonderful. I was so honored that I got to get you to come on this show. I really do think it would help these kids if you put a 1 hour online CE course. I think it would bridge the gap between, because once she hears you for an hour, she's going to fall in love with you. And like you say, Vegas is the best thing about Vegas is it's every city in America has existing infrastructure to fly there at convenient times. The hotels are low cost. And like right now, the ADA meeting next week is in San Francisco. I mean, these dentists are going to pay $400 to $600 a night for a crappy hotel room that has 5 homeless people living at the front door. Vegas is just great, and just love it. But thank you so much for coming on the show. If you ever want to write something for Dental Town Magazine or an online CE course, we'd love to have it. It's been a complete honor to podcast you today. Thank you so much.
To find some more information, they can go to occlusionconnections.com. We're always passionate, and Howard, thank you very much for having us on your podcast. It was a great honor, and I hope what we shared will make a difference to bring our profession together. Thank you.